Good afternoon. First of all, thank you, Sam, for this great webinars you are creating over the months and years now, and I'm really honored to be here. I already saw beautiful presentation of Professor Nair and Professor B, and I see Dr. Hernestniemi in the audience, one of our great mentors, and many other friends and colleagues. So I'm going to talk today about a topic that's very near and dear to my neurosurgical interest. And also, please, whenever I breach the time, just let me know and I'll stop. You know, over the years, I looked into this visual preservation. Is it possible really when the tumor is compressing the optic nerves, when you have parasellar lesions, and when you are faced with all this difficult anatomy and difficult problems, what is the trick? Is there anything scientific? Is there anything technical that you can do to preserve the vision? Is there something that makes the difference where you can at least preserve the vision in your patient and not worsen it or even improve it? So, when I went to the literature to analyze what do we know, I really didn't get very much information. First of all, it's spotty given, presented, and reported. And then visual improvement ranges from like 1/3 to 2/3. Some people give very spotty information, and then, what does it depend on? Does it depend on preoperative visual function? Does it depend on status of optic nerves and retinal cells, length of preoperative deficit, size of tumor, type of tumor? Do meningiomas fare differently than pituitary adenomas or craniopharyngiomas? What type of surgery you do? How to quantify it? So didn't get me very far, and to me, it's still unclear. So what do we know is the most common lesions are pituitary tumors, meningiomas, tuberculosella, dorsal olfactory groove, clinoidal, craniopharyngiomas, aneurysm, orbital tumors. We know that there are two things there: direct compression and vascular impairment. Which one is guilty? I mean, is it worse that direct compression is causing blindness or vascular impairment, or both? How much percentage was? And then where are the points of tethering of the optic nerve? Being displaced from below or from above or from the side? Obviously, we know that's arachnoid membrane and fibers, falciform ligament, optic canal, and anterior clinoid. And these are some of the pictures of Dr. Roton and others who did beautiful anatomic studies in these areas. And then we know the optic nerve segments, cisternal, falciform, distal, canalicular, and orbital. So, when I do these procedures, what I learned from my mentors, Dr. Al-Mefti being the main, is you go through all these steps, take the roof and lateral wall of the orbit and take the clinoid, open the superior orbital fissure and lateral wall of the cavernous sinus, and then extradural removal of the clinoid, as I mentioned, open the cisterns, release the CSF. But and these are some of the stages. One of the things that I realized that, gel foam powder, my friend and one of my mentors, Ali Krisht, liked to use Tusil, but I think gel foam powder much better improves the bleeding from the cavernous sinus. This is just one side technical note. And then, of course, as I mentioned, removing extradurally anterior clinoid, opening of the falciform ligament, optic nerve, release, etc. And then, of course, as Professor Yashagil has taught us, to open the arachnoid membrane, release the fibers, and then basically when we need to open also lamina terminalis. But what I was looking to get some sort of scientific validation, or at least to check what happens when you do the stages of dissection. And whenever you want, at least in my experience, some to gain some knowledge, you go to my residents. These are my residents, and I told them, how can we measure the pressure of the optic nerves to different stages of dissection? And of course, Dr. Basma, a great guy, he told, oh, that's very easy. You put a thread around the nerve and measure, and he has done it before. So we did this study where we opened cisternal, falciform, and optic canal decompression, and looked into the optic biomechanic. And this is published online. It'll come out in February. And so first, what we looked into the falciform ligament. How does it look? What is this ligament that we are cutting? So you can see here the thickness, the lack of vascularity, which we pretty much knew, and it's very similar to dura periorbital optic nerve sheath. And then when we looked into the vascularization, we found out that there are two different segments of the optic nerve. One is cisternal segment and proximal canalicular falciform segment. You can see here very poor vascularization of the optic nerve in the arachnoid space, and also as it enters the optic nerve canal. You can see that there is peripheral network and comes around and forms patchy network within the optic nerve. But look here at the distal canalicular or orbital segment. Look, this is there is central retinal artery, obviously taking off from the ophthalmic artery, and look this abundant network of vascularization as it comes to the globe and enters into the eye. So this is one of the things. Obviously, there are two different vascularization patterns. Then what we did is we did 3 stages of cadaveric dissection. First, what we did, you can see here the thread, and we did testing with this manual tension gouge, which is 4 meter, produced by this company, which I don't even know, somewhere in Burlington or something. So basically, what we first did, we opened the dura, obviously released all arachnoid adhesions, and then measured the vertical pull of the optic nerve, as you can see here on the left, and in the middle side pull. And by the way, you can see here 3 different sections of the optic nerve as we did our dissections, as I mentioned: cisternal with very poor vascularization, falciform, poor and transitional, and then canalicular as well. And then distally, once we open all that, distal to the canal, very, very rich vascularization. You can see here ophthalmic artery going into the optic canal. So in the first stage, basically, we measured that, recorded. Then second stage of dissection, we opened the falciform ligament, lifted with the nerve hook and cut with the sharp knife. And then again, did the measurement with upward pull, with side pull, and also measured through every stage the optico-carotid space and progressive increase that we gain with these maneuvers. And then as a third stage, we, as you can see here, took out the clinoid, completely opened the optic nerve canal, as you see here. And you can see right on this cadaver picture how the optic nerve becomes lax and very friendly looking, as opposed to tense optic nerve before this dissection. And again, we did all our measurements. So as you can see here, these are different segments: cisternal, falciform, canalicular. You can see here you use always a similar force, so force is always applied similar around 1. And then you can see here the dip and the tension. And every time when we measured the tension, and then we measured the space. And you can see how the tension obviously decreases as we open this. And you look at these differences, the tension at the beginning, and as we progress with our dissections, and then the dip. Look at the dip, how the dip increases with this maneuvers, as well as optical carotid space. So here is the table showing the increase of optic carotid space in cisternal, falciform, and canalicular exposure. Area at rest is 9.7, 11, 17. And added area, look at this, 6 millimeters, 11, almost 12 millimeters, and 30 millimeters after all these maneuvers, and obviously statistically significant difference. When we compared this mobility and tension between the upward pull compared with the side pull, we realized that upward pull or movement of optic nerves superiorly rather than the lateral is significantly better and better tolerated. We saw it intraoperatively, probably because of the shape of the optic nerve and some other forces, as you can see here, that are tethering the nerve, falciform ligament, and optic nerve canal. And you can see here again, the force is always very similar, around 1. The dip progressively increases, but significantly increases with upward pull as compared to side pull. So this is another thing with this study that we proved, at least on cadaveric specimen, that upward pull is much better tolerated, much less tension, and much more space than the side pull, or the displacement, or dissection, or retraction, however you want to call it. And you can see here progressive values. And finally, we compared side pull to side pull at each stage of dissection, and then upward pull to upward pull at each step of dissection. And we noted that progressing every step of the time, the dip increases, the tension decreases, as you can see here, and then it is always better after the next step of release of the optic nerve. So in conclusion of this study, obviously, all these maneuvers with removal of the anterior climbing optic canal and roofing, cutting of the falciform ligament, and arachnoid release increases the optic nerve mobility and optic carotid space while decreasing the nerve tension. It also improves, obviously, optic nerve vascularization, as all these tethered areas where the vascularization is poor improves. I tend to compare it like in the thoracic spine, upper thoracic spinal cord has transitional vascularization, where a robust vascularization in the cervical spine and lower thoracic and lumbar spine is much less pronounced in the upper thoracic spinal cord. So this is a sign of similar situation. And then the tension, as you saw, the optic nerve tolerated superior inferior manipulation much better than the lateral to medial or medial to lateral, and upward manipulation created a larger space. And of course, as we mentioned, this vascularization is very, very important. So just few, and Dr. Sam, just stop me whenever I go through my time, but I'll show you, I have now a big series of patients with this proven improve of the optic nerve function. You can see here, this has been also published. You can see this lady presented with almost right-sided blindness, significant decline in her vision. You can see here, she had the renal cell cancer metastasis. You can see the tumor involving the optic canal and proximal orbit. And I'm going just to go quickly through this case. So this is basically just exposure, frontal temporal, sphenoid wing, drilling. Always when you work around the optic nerve, you have to have abundance irrigation. This is the drill I use. I like coarse diamond drill, and there has to be significant irrigation to cool off the effect of the drill. So next is getting towards the tumor. You can see here opening of lateral wall of the cavernous sinus. Why do we need that? Because it's much easier. They say, well, you don't really need to open the lateral wall because your pathology is more proximal or medial. Well, there is no safe removal of the clinoid with 360 dissection without moving the dura and opening of the lateral wall of the cavernous sinus, in my mind. You can see here the vascularization